Okay.
So just wait 5 seconds. Okay, welcome everyone. It is my pleasure and an honor to introduce this EKPF new EKPF webinar about rare and kidney diseases and genetic diseases. And of course, EKPF is committed to raise awareness about kidney diseases and bridging the knowledge gap about these unmet needs and unpleasant symptoms related with kidney diseases. We are claiming about the registries and data about the rare kidney diseases. And it is my honor to introduce our moderator and our experts. So the moderator that we have is Tess Harris, who is president of FEDERG, the Federation of the European Renal Genetic Diseases. So Tess, it is my pleasure, and the floor is yours. Thank you very much.
Thank you very much, Daniel. And I'd like to thank in particular the European Kidney Patients Federation for organising this event at what's also an exciting time for everyone affected by the rare and genetic kidney diseases. So as Daniel has said, I'm Tess Harris, and I'm currently the president of FEDERG, which brings together the rare and genetic kidney disease patient groups across Europe. And I'm also the chief executive of the Polycystic Kidney Disease Charity in the UK, and I'm in fact a kidney patient as well. So I said it was a bit of an exciting time because in a month ago, the UN adopted a resolution on addressing the challenges of persons living with a rare disease and their families. And this is a huge milestone in rare diseases and of course, for people affected by rare genetic kidney diseases. This recognises that over 300 million people are living with a rare disease, and of course, a large number of those will have kidney disease. And it's also recognising that the rare diseases affect the families and the loved ones. And it calls in particular for action from all the countries of the United Nations to focus their efforts and investments on rare diseases. And the next step is the formal adoption of the resolution, which will take place in December. So a big milestone for us all. And another important event that's taking place actually right now is a conference, which is the first rare and genetic kidney disease drug development conference, which has brought together pharmaceutical industries and regulators to discuss how the latest scientific research is being applied to drug pipeline progress and the development of new therapeutic treatments in many of the conditions that we all know and live with. So we have two wonderful speakers today. Our first speaker will be Dr. Jonathan Barrett, and he is leader of the renal research group within the College of Life Sciences at the University of Leicester, UK. And he's also known to many of us as an expert in IgA nephropathy. Our second speaker will be Francisco Monfort-Villar, who's the president of the ASUA, that's the Atypical Hemolytic Uremic Syndrome Association in Spain. He'll be joining us shortly. But now it gives me great pleasure to hand over to Dr. Barrett. John, over to you, and I believe you're sharing your slides with us all today.
Yeah, thanks, Tess. Let me just share my slides. So I'll just check that everyone can see my slides okay. Tess?
Yes, it's okay.
We can see them.
Perfect. So as I was saying to Tess before we started, I feel a bit of a fraud with this title because I'm a doctor who looks after kidney patients, and actually the best people to tell us the humanistic burden are the patients, the people who have rare kidney diseases. But what I thought I'd do is take you through how we as doctors are trying to better understand the burden of kidney disease so that we can utilize that to improve the care that we give for patients with rare kidney disease. And for that, I'm going to use IgA nephropathy as an example. And so for those of you that don't know, IgA nephropathy is a rare kidney disease. It's the most common form of primary glomerulonephritis globally. And it carries a lifetime risk that up to 50% of patients will go on to develop end-stage kidney disease requiring a dialysis or a transplant. It's a disease that's estimated to be present in 1 in 10 patients who are on dialysis worldwide. And if you're fortunate enough to have a kidney transplant, unfortunately, this disease can recur and you can lose your kidney transplant because of this condition. And just to give you an idea of the burden of this disease, globally, you will see that, this is the number of people estimated to have IgA in certain parts of the world. So 200,000 in the US, 200,000 in the EU, much more higher proportion of patients relative to the population in East and Southeast Asia. So this is rare, but as Tess mentions, when you add all the rare diseases together, they form a very large proportion of disease burden across the world. And so when I give talks, normally I'm giving the talk from the perspective of the doctor. I'm talking about treatments, I'm talking about the way we think the disease develops, and I'm talking about my perspective of looking after patients with kidney disease. And of course, that's absolutely fine, but what we really want to know is what is impacting on the lives of kidney patients, because by understanding that, we can tailor our treatments to the individual to improve their quality of life. And so I'm not going to talk about my perspectives at all, actually. I'm going to talk about how we as a community are trying our hardest to work with our patients to understand the impact of living with rare kidney diseases, and in particular, the rare glomerular diseases. You'll be pleased to know, and Tess has already alluded to this, that the regulators, the agencies across the world that approve drugs and make them available for us to prescribe for you, are absolutely committed to understanding the impact of disease on the quality and quantity of life that you have. And this is the FDA, which is the regulator in the United States. And here you can see that as part and parcel of the data that they're receiving to decide whether a drug works or not, there is a significant increase in the amount of data related to patient-reported outcomes. And here I'm talking about outcomes that the patients are telling us in terms of symptom burden, in terms of quality of life, rather than biochemical measures from blood tests and urine tests. We're actually using the data that patients are telling us about how the disease is impacting on their lives and how treatments are improving their quality of life as a way of actually approving therapies. And there are a number of therapies that have actually been approved, not on a biochemical result, a blood test or a urine test, but on the fact that they actually made patients feel better, which is a fantastic advance in where we are in terms of thinking about how we measure the effectiveness of any drug. Sorry, my computer's being a bit slow. So how are we doing in IgA nephropathy? Well, in the UK, we have a very vibrant patient group. We have this YouTube channel, which we post a range of resources for our patients, videos from our information days, videos of when patients have come and looked around our laboratory, information on how to manage certain symptoms. And so we've always in the IgA nephropathy group, certainly in Leicester, being absolutely clear that the priority of our focus must be our patients. And we want to work with our patients to understand what's important to them and how their issues we can address in our research questions. We have an active Facebook group, and I know there are a whole raft of different social media groups that allow patients to interact, and this is just one of them, set up by one of my patients actually. And this is a great way for us to be able to disseminate information and for patients to make contact with one another. One of the most abiding memories I have of one of our first face-to-face patient groups was patients with IgA nephropathy actually finally meeting another patient with the same disease as them. they have this condition, but they've never met another patient to be able to share their experiences. And that came through loud and clear when patients have the opportunity to meet and talk and discuss and share experiences. And this is one way in which they can do that through social media. Clearly, it doesn't beat face-to-face interaction, but we go with what we have at the moment. The other thing that we've been really interested in trying to understand what's important to patients is we've used some research methods to look at what patients are talking about on social media and to identify the common themes that are unmet needs for patients with a rare kidney disease such as IgA. And we've used this to identify the things that are important to patients. And here you can see some of the key themes that were identified. Some of these you will recognize if you have any form of chronic kidney disease: potassium, phosphate, salt advice, how do you manage this? And then you've got specific things about the disease. Will my IgA get worse? What treatments are available? Information on the kind of tests that we do, the genetics, and whether this is a disease I can pass on to my children. And so this was allowed us to get a real idea about the issues that patients talk about and are worried about, but may not actually ask us about in clinic. Because that's really important to understand perhaps that unmet need that we aren't addressing when we meet and talk to our patients. And you can see here the numbers of posts around these particular areas. And interestingly, IgA nephropathy is by and large thought of as an asymptomatic disease, a disease that is associated with kidney function decline, but doesn't actually give any symptoms. And what you can see the most posts about in the IgA nephropathy workgroup were actually symptoms. And this is a disease that we teach our medical students shouldn't cause symptoms. So clearly there's a complete disconnect here, and that we haven't been listening to patients to understand how this disease is impacting on them. And so what we did to address this is, you'll see if you go onto the Facebook page, this top panel with the purple backgrounds, is we had one of our patients interview us and go through the questions that came up in this research to ask us for our answers. So we have dietitians, we have psychologists, we have doctors, we have other people, part of the team, answering the questions that came up that seem to be the questions that our patients really want answers to. And this is a work in progress, but this is one of the ways in which we can meet some of the unmet needs that our patient groups have by being able to listen to what they're saying to us and develop resources to try and answer those questions. But this isn't just happening in the UK. So there is a big theme. So I don't know whether this is a European group, but there may well be some patients from outside of Europe. But this is a really interesting concept here, where the drug regulator and the National Kidney Foundation, which is a body within the US, have brought together IgA nephropathy patients to hear their voice, to hear what's the unmet need is. So this is happening not only in the UK and in Europe, but across the Atlantic as well. And here you can see, and it's really worth reading the report from this. If you go onto the National Kidney Foundation website, you will hear the key things that are important to patients from the US. And these mirror very closely the kind of things that we were hearing from our UK patient group that are unrecognized and really unstudied in patients with IgA. This feeling of continual excessive exhaustion and tiredness, the idea of brain fog, mental health challenges that patients face with a chronic kidney disease, particularly one that we don't know the cause and we don't have a treatment for. And you can read for yourself how these symptoms impact on the ability to enjoy life and get as much out of life as possible, both physical activities, but also work, school, participating in social events. And I'm sure this will ring true with many of you who are listening to this talk. The other initiative, which I think is really important to understand, is the SONG initiative, which I'm sure many of you will have heard about. But this is about asking patients, what is important to you that we should measure when we're testing a new drug for kidney disease? And so there are a variety of these initiatives. It's called the Standardized Outcomes in Nephrology, and one of them is around glomerular disease. And these are a group of rare kidney diseases, and I was lucky enough to be part of this. And this has taken focus groups of patients. It's taken a survey, a global survey, to find out what are the important issues that patients want to have measured as part of a clinical study to see if it improves quality of life and life participation. And there's been a variety of publications come out of these. I'm not going to go into these now, but these are giving us a rich source of what the priorities are for patients with kidney disease, with rare kidney disease and glomerular disease, because we want to be able to incorporate these into how we design studies to see whether a treatment works. And so here you can see, not surprisingly, patients want to know their kidney function's getting better and that they're going to live for longer, but actually life participation, fatigue, anxiety are things that we wouldn't normally think about when we're assessing a new treatment for kidney disease, because we're obsessed with creatinine and proteinuria, as I'm sure you'll appreciate as whenever you go to see a nephrologist and your blood pressure. But actually these are things that patients regard as significantly important to them, that we need to be starting to think about addressing in all our new treatments that we're trying to deliver and in the way that we look after you. And here, just ranked according to the importance from patients, you will see here many of the features that are important to patients and they want to be assessed and addressed in any clinical study. And I'll let you just scan down there, but I'm sure a number of these will ring true for you, outside of the obvious ones that as doctors we are always looking at in terms of dialysis, transplantation, and blood pressure and cardiovascular disease. But there's lots of things here that are equally ranked important by patients who want to enjoy their life here and now, that we need to start considering in what we do going forwards. So I think we've made a start. I think as doctors, we are privileged to look after patients with kidney disease, and we need to listen to you more. I strongly believe we need to think about how we look after you and focus on what's important to you, as well as the numbers that we see when we do our blood and urine tests. And the way we're going to do that is we need to get the multi-professional team, the doctors, the nurses, the dietitians, the pharmacists who look after patients with kidney disease to continue working together with the researchers who are actively trying to look for new treatments, alongside the pharmaceutical companies who are equally involved and engaged in this process. And all of this centered around you, the patients, because unless we involve you at every step of this process, we are going to make mistakes, we are going to miss important things, and we are not going to deliver a truly holistic approach to how we look after you. So I want to hopefully enthuse you to say we are aware that we need to be thinking about more than just serum creatinine and your kidney function. We want to look after you as a whole individual, and we need your help to do that because you are the experts. You are the experts in your disease and in your health, and we need to listen to you to be able to understand that and to be able to move forward with better ways of looking after you. So I'm going to stop there and I'll hand back to Tess.
I am online, but I've got the same issue we had at the beginning with the video not working correctly. Perhaps Juan Carlos, if you're there, if you could reset the video setting for me. But in the meantime, I'd just like to thank John, Dr. Barrett, for introducing the topic and also for highlighting the advances that have been made in recent years, and particularly the work of the SONG initiative, the Standard Outcomes in the Nephrology Group, which began a few years ago now, and some of us have been fortunate to be involved in many of the SONG initiatives, and we ourselves in PKD have a SONG PKD set of core outcomes, and pretty much the themes that have been identified in the SONG GN were very evident in all the other songs, from dialysis, transplantation, etc. And the life participation came out as a very strong patient-reported outcome, which is being further developed now into tools that can measure it and be applied to anyone with kidney diseases, including the rare ones. So thank you very much, John. I think we're going to take questions at the end, and Paco has now joined us. So I'd like to invite Paco to put your camera on. Hopefully you're there.
Hi, good evening.
Hello. So
Yeah.
I'm not sure you, thank you, and hopefully your video will start, but whilst that's being set up, I'd just like to introduce you to the audience. So Paco Francisco Monforvillar is the president of ASUA. That's the Atypical Hemolytic Uremic Syndrome Association in Spain. He's also a member of FEDEG and vice president currently. So welcome, Paco.
Yeah, I cannot switch on the camera yet.
Yeah, there's a bit of a technical issue that will be fixed.
Okay.
Yes, there you go.
Yeah. Sorry, I was on the road and I was a little bit late. Okay, let me start to share a presentation. So let me check exactly where. I think that here. No, screen, share screen, yeah. Okay. Okay.
We can see your screen now, Paco.
Okay, great.
So over to you.
Okay. Hi, good evening, everyone. I am Francisco Monfort, Paco as a nickname for all the friends, so please call me Paco. As Tess said, I am president of ASUA, is the Spanish Association for the Atypical US patients, and also a founding member of FEDER in 2015. Our association was born in 2012 and as a support platform to inform and advise patients of atypical US and their families. We collaborate with nephrologist societies in addition to other patient associations like ALCER. ALCER is the Association for the Fight Against Kidney Diseases. FEDER is the non-profit federation of the European Association of Patients affected by rare and/or genetic kidney diseases. Also, we participate in ERCANET, the European Reference Network for rare kidney diseases, and obviously we are supporting as much patient association around the world. Probably because our Spanish language, we are really active and supporting patient associations and doctors in South America. Well, I would like to introduce our ASUA Observatory. It's a tool that shows that the research and teach doctors definitely save lives. Probably this is the largest study conducted by a patient association on these rare diseases. Just a couple of years ago, we went through 118 atypical US patients in Spain, where was carried out directly survey with them. So this is this information that you are going to see right now is definitely a real data, and all the question was also carefully developed in collaboration with doctors and researchers. Well, this is a really great image about what was the atypical US from middle of 90s. As the literature in 1955, more or less is when was the first diagnosis of atypical US, probably when born the name, okay? And until 2010, we basically this disease was not poorly on research, and treatments were very poor. As for example, in the 80s, start with the plasmapheresis, or in the 90s, the double kidney and liver transplant. So you can imagine that the treatment was really poor and very risky. Everything changed in 2020 and 10 when appeared a new drug called eculizumab, where completely changed the life of the patients and also of the doctors. You can see on the left-hand side this very dark picture, and afterwards from 2010s, the new image, the new picture that is very clear and sunny day, more or less that happened with the patients. Before the 2010s, basically 90% of the patients lose kidney function or die. So we are gonna see what is a typical HUS today. So one of the main concerns when this disease arrives to a family is to know about the rest of the family members, because usually the atypical HUS is a genetic disease. So probably this is an inherited disease, just a few ex novo. So the good data is that probably only one member, family member, could have the same genetic variants. But the most important, and this is a positive info for the patient and for the family, that below 1% of this family member could debut on this disease. So it's something that many of them are asymptomatic. So this is quite positive information for the family. Another important info is that the good management of this disease by the doctor and effective treatment reduce the number of debuts. So we still see cases where the discontinuation of the treatment without proper monitoring causes a new debut of atypical HUS. So it's really important the doctors learn about the treatment and learn about the genetic variants of each patient. This information, this data is going to be also really important on the following slides, where we discover that 66% of the patients are women versus only 33 males. Why? Well, basically because women are exposed to more triggers, such as pregnancy, childbirth, contraceptive, etc. Not because the women itself. This is important to establish the guidelines for the transmission from pediatric to adult. So since 50% of the patients are under 15 years of age, especially for the girls, because they will be exposed to more triggers in the future. So it's important doctors learn about the disease and learn about this situation and the special triggers. Knowing that, we can teach also the patients and the families to care and to be also be aware about the triggers in the near future. We can see that once after, let's say, 50s, the number of debuts could be really, really low. Again, in order to manage the patients and to study the proper treatment, is really important to make the genetic studies. So we can see that up to date, 86% of the patients has carried out the genetic studies. So will be easier to manage the disease and to avoid the future debuts. What about genetic studies to the rest of the family members? We think like a patients that is really important because okay, we understood at the beginning of the slides that probably less than 1% of the family members will debut on the atypical US. Okay, but it's still a percentage. So it's important to carry out the genetic studies also to the rest of the family members. So we know that the prevention could save organs and could save lives. Today, it's easier to do the genetic studies, and much easier once we study the first patient. Afterwards, to study the genetic studies to the family will be easier, will be faster, and will be cheaper. So definitely here we can see that between 1 and 3 months, the doctor could have the result and then adapt the proper treatment. We need more research because 50% of the genetic diseases are not yet known. We can see that probably the most dangerous is the factor H, definitely. Unfortunately, only 5% with MCP, which is not a really strong or dangerous trigger, but definitely we have to push the researchers to keep looking after all the not detected or not known situations. The main triggers, well, definitely E. coli could be one, but afterwards, as we described at the beginning, for women after childbirth, oral contraceptive, during pregnancy, infection, transplant, drug intakes, so could be a large variety of triggers. To know the symptoms could be also a good information for the patients and for the families, because knowing the symptoms, they could act quickly before new debuts of atypical US. It's confirmed by this information that 65% of the patients decrease in urine volume. So definitely the name of uremic syndrome is a right word. This is another important information and important data. How long did it take to be diagnosed with the disease? Well, today we can see that around 50% of the patients are well diagnosed in less than 1 week. As we remember, the first slides were the dark picture. Before 2010s, some patients it took around 3 months. So in 3 months, the disease could definitely damage many organs or even the life of the patients. Another positive data, how many doctors did you consult until the final diagnosis? Only 2. This is another proof that the doctors now know about the disease and they can react very, very quickly, so saving the kidneys. Here is definitely doctors. The nephrologists are the main players to diagnostic the disease, but we can see that also up to 50%, 48% of doctors were hematologists. But again, remember that 50% of the patients debut on atypical HUS before 15 years old. So pediatricians is another key doctors to talk with them and to inform and to teach about this disease. Well, basically in Europe and in Spain, in this case, mainly all the patients have access to an expert center. But we remark that the most important is for those doctors in a smaller hospital to meet other colleagues to consult. Because, for example, in Spain, there are less than 1 patient per year, so of atypical HUS. So it's really, let's say, difficult that a small center, a small hospital could have 1 patient in the life. So it's really important for the doctors to be, let's say, open-minded, and immediately they see patients to call other doctors with more experience. The therapy is also important. As I said, after 2010, eculizumab or similar drugs is definitely the right treatment, while in the past, plasmapheresis, kidney transplant was not the proper treatment, because we saw that a kidney transplant without eculizumab or similar could have another debut on atypical HUS. So definitely today, a good reaction, a good rapid diagnosis, and using eculizumab definitely could stop the disease. Current situation, again, treatment with eculizumab is the top one. A few were symptomatic, probably because the genetic variation could allow this situation. Definitely doesn't happen with factor H. Okay. And probably the good thing is that the combined liver and kidney transplant today, there is none. This is, again, as I said at the beginning, this was the only treatment or the only solution in the past before the new drugs appeared in 2010. Definitely, let's hope that the deaths disappear from this list. We can see that, still 47% patients with chronic kidney disease, so kidney being affected. Probably this 42% of dialysis is still from patients which, by this situation between 2005 and 2010, okay? But we can see that right now, up to 30% of the patients, they don't have any consequences. Well, we are pretty sure it's because doctors really did a really fast diagnosis and use the new drugs. So compliment for that. A typical AGUS is not just a rare disease. It's a disease which affects not only to one person, affects to the whole family. Because again, remember that patients will be most of them under 15 years old. So definitely part of the family may just lose the job. The family needs external help, okay, or need a special school education. So it's important to mention that and to care especially about the situation with the families. Fortunately, we can see that again, 44% been not affected because the disease. So again, we link the data and we saw that all those patients were well treated with the new drugs. We were curious to see exactly how the patients in very difficult moments, if they were satisfied with the information received by the doctors. And we can see that 75% of them are very, very happy or quite happy with the information received by the doctor. So again, congratulations for the good doctor-patient relationship is essential to control a chronic disease. Another important today information is to know where the patients receive the information. In that case, well, up to 72% of the patients receive the information from Patients Association, also from the hospital, okay? And probably we should care a little bit about internet, because internet is very wide, and depending where they are looking for, the information could be really good information or completely wrong. So it will be important that doctors, hospitals, national association publish clear information about the disease. Well, what the patients and the families says that they need more information, again, linked to the previous slide, but for them are clear that more research is really, really important. So just some notes to remember. There is a before and after 2010s. Up to 40% of the patients are treated with eculizumab, with new drugs. More than 30% of the patients have recovered without consequences. So this is really, really important. Again, those patients are treated or develop or debut on a typical AGUS after 2010s. Really important also the transition from pediatric to adults, because 50% of the patients are occur before the age of 15. Also important that 66% of the patients are women. Okay. 72% of the patients contact Patient Association for information. And probably also the society, the whole population demand more research because they understood that research means save lives. Since 2015, many countries and many patient associations, we researchers and doctors, we make awareness about this disease. So we would like to invite you, all of you, to join us next September 24th to make this rare disease more visible. Thank you.
Thank you very much indeed, Paco. And again, we've got a little bit of a technical difficulty with my video not starting, hence you can't see me, but you can hear me. Hopefully one of the other hosts will sort that out whilst that's happening. But in the meantime, I'd like to thank you for such an enlightening presentation, and congratulations on the Atypical HUS Observatory and the insights that you've brought forward from the demographics, from the predisposition factors, the carrier information that perhaps would alleviate some of the stress and anxiety that many parents or siblings will feel about being a carrier of a rare condition. And also to highlight the impact on patients and families, which is so important. And to also demonstrate the incredible impact of an effective treatment. And that's very noticeable from your pre-eculizumab, post-eculizumab references. So I do hope you'll be able to publish that data so that it will be spread more widely and become more widely known.
Mm-hmm. Yeah.
We have had a couple of questions, and there's one that I'll ask you first, which came into this question to both of you. So this is from Manuel, who has pointed out that, of course, it's important that the clinics, the physicians know the perspectives of the patients, but how do we get the patient perspective embedded into clinical research right from the very beginning to make sure that patients' unmet needs and priorities are reflected throughout the whole research drug development process? John, if you come off mute.
Yeah, so I think that's incredibly important. And in the United Kingdom, the grant agencies that fund our research will not consider an application unless there is a patient perspective included in the application. We have an acronym PPI in the UK, so patient or participant involvement. So it's been very clear from the funders, both the charities and from the government funders, that there must be patient involvement in any research that we do, even if it is experimental work in a laboratory that is around the genetics of disease. They want to know that patients are involved and are understand what research we're doing, and they can understand the importance of it. So I think it's beholden on funders to actually insist that researchers talk to patients, and good researchers, no matter whether they have to or not, will always talk to patients. And I think certainly in your hospitals, I can only speak for the hospitals in the UK, but we have a renal patient group that gives us feedback on the performance of our kidney unit and is involved. If we're going to develop a service, we ask our patients how that service should be developed. So I think it's really important from a clinical perspective that you find out from your hospital what engagement there is with patients, and from a research perspective, what involvement there is with patients within your country and your funders. And I think, Tess, you've been involved with Kidney Research UK and a number of NIHR initiatives. And it is absolutely clear we are in the UK, we do not move research ahead unless we involve patients at every step of the way. And I'm sure that's the same in other European countries. It's just a matter of finding out, how that is in a specific country and what the mechanisms are.
Yes, you're absolutely right. And the regulators are insisting on it as well. And what's been great in the EU through the Horizon programs is that they actually mandate patient engagement, and they even insist on a budget. Last year it was 30,000 euros, which is a substantial budget for patient involvement compared with the zero we would often get. And I would like to see this more widely mandated, that there has to be a proper budget for patient involvement rather than our letters of support and nods of approval.
Yeah, and Tess, I was at the European Medicines Agencies for a new drug for IgA nephropathy, and there was a patient on the panel asking questions. So it is recognised from regulators and from governments how important this is. And if it isn't recognised in the country that you're from, then now is the time to start pressurising and thinking how you can utilise models in other parts of Europe.
Yes, absolutely. Going back to clinical research, so Paco, what experience have you had of involvement with researchers either in Spain or internationally?
Well, we are not officially, but yeah, we are very close to researchers, and we've been invited to seminars and to congresses about complement system, and well, again, fighting or working very tight with them, but not in the official way. Definitely is important for the patients and also for the researchers to understand which are the real problems of the families and the patients. So so yeah, definitely I would say that is really positive, and probably also probably the work that we can bring is not too much on the proper research. Definitely is really important for them to show, as for example of our association as observatory, that these are really positive results. So so definitely is a real proof that on the atypical HUS that this research definitely not only saving organs but saving real lives a lot.
Yeah, and Tess, at our recent scientific meeting for IgA nephropathy, our international meeting, we had a patient panel where we had patients from China, from the US, from England, and from the Czech Republic. And we had an hour listening, the researchers had an hour listening to patients' voices. And one of the things I found is in my laboratory in Leicester, we have a lot of scientists who spend a lot of time researching a disease, and they've never met a patient with the disease that they're researching. And they absolutely love meeting patients because they can put a face to the work that they're doing. They're dedicating 3 or 4 years of their research life without ever coming. So we've had an open lab, we had patients in, and the patients, our researchers got as much out of that as our patients did, because I have the privilege of seeing patients every day of the week. The researchers in the laboratory don't. And I say the same about pharmaceutical companies. One of the things I say to pharmaceutical companies who are going into, say, IgA is ask a patient to come along and talk to your team about what it's like living with the disease. There is nothing more motivating than understanding from the horse's mouth, as it were, what it's like, what these people are doing in terms of developing a new treatment to treat a patient, and they can hear from the patient themselves about how that disease is affecting them.
Yes, and it is great to see it expanding. Different type of question now that's coming through WhatsApp, which is how do we raise the awareness of healthcare professionals about the rare kidney diseases? I think especially where there's no effective treatment like eculizumab, but where patients and families are coping with the burden of the condition and don't feel that that aspect of their condition is being listened to or managed effectively.
Well, definitely with the doctors again. This is it has to be a good, let's say, relationship with doctors. It's really important to understand them, to understand doctors and researchers, and it's because and it's also important to understand the patients in a really terrific situation. So that's why from the association we try to make that kind of meetings, and definitely to establish a kind of awareness day in order to make more human relation. Okay, doctors usually they are really busy every day looking after many patients and different diseases. So it's important to highlight how the job and dedication definitely brings positive results. So again, the awareness day would be just one of the keys, but the most important is to bring and to, as we did with the ASU Observatory, just to focus that definitely looking at the past, that the results, the positive results are there.
Thank you, John. Any perspectives on?
I think it's a two-pronged approach. The first is we absolutely need to educate kidney doctors and general doctors about disease. But what you already touched on is, so for instance, atypical HUS, we cover a population of 2 million. We'll perhaps see one new case every couple of years. So in one way, we do need to raise awareness to make sure that that early stage of diagnosis happens quickly. But actually what we want are for the patients with rare diseases to be looked after in centres of excellence, because we cannot have everyone trained to manage every rare disease, and every rare disease comes with its own nuances. And so I would also suggest that actually, if you aren't getting the right treatment or you haven't got access to the expertise, as a patient, is to vote with your feet and ask if you can see someone who has the expertise and experience. And so I get lots of referrals about IgA nephropathy. And quite frankly, the kidney doctors looking after these patients are very, very happy to let me deal with that, because they've got, as already been mentioned, they've got lots of other things on their plates. So I think we've got to feel about empowering patients to understand what's available in their country, and low country organizations will have good networks with experts, and we need to facilitate access for patients to the people who have the right knowledge and experience for these very rare diseases. I mean, I diagnosed a case of dense deposit disease, a very rare complement-mediated disease, first time I've ever diagnosed it. And I'm a little bit older, you know, but, you know, I will probably never see a case again. But the first thing I did was call Newcastle, which is the complement centre for the UK, to get advice. And so I think we need to be aware that actually doctors do not have the answers to everything, and for rare diseases we need to go to the experts for that rare disease to get the best care and the best advice.
Thank you. And of course that emphasised the importance of the European reference networks, which are set up to do precisely that, to improve the variation in access to care, which we know exists around Europe. There was another question around what knowledge do we have about the variation in access in different countries, or even different parts of the same country for patients with the same condition. But I don't know whether you know, John, if that data has been comprehensively surveyed and brought together in a report.
Yeah, so I don't know for Europe, but I know NephCure, which you may well have heard of, is a US-based. So the disparities in the US are phenomenal when you talk to patients. Far more disparate access than in Europe. And I think they have identified and quantitated how difficult it is in the US to see the right person. I don't think we have that data in Europe. But you're absolutely right, it would be fascinating. I mean, I thought the data that you presented on access for atypical HUS in terms of numbers of doctors you have to see, how quickly you've got a diagnosis, is fantastically informative. And I wish we had data for all the rare kidney diseases. But I think that's perhaps something we should look to do in the future.
So one that question did come up in the recent ERCnet meeting that was held just before this, where there is an intention to survey the ERCnet members, so their hospitals, to ask questions about access to genetic diagnosis and also, of course, PGD and so on across Europe. So there's some moves being made in that direction, which are looking good. Well, it's already 5:30 here, 6:30 where you are. There was a very specific question in the Q&A, John, about IgA, but I'm not sure whether you wanted to quickly answer that or just.
I'm just trying to see it.
It was when can we expect future breakthroughs in cure or treatments for IgA?
So I would be looking for an early Christmas present. So there are drugs now that have completed their studies, and there's data with one drug with the regulator in the US. Another company is going to be putting its data towards the regulators early next year. So by this time next year, we could have 2 approved therapies we can prescribe for our patients. We've never had those drugs. The future has never been brighter for IgA nephropathy. We have 5 different drugs currently in studies that could get them approved. And so I hope that we'll be able to mirror the impact of eculizumab and be able to offer our patients treatments that work, that are safe, and aren't associated with significant side effects. So I would say if you've got IgA nephropathy, it is the golden age at the moment for new therapies, and the future is incredibly bright.
Well, thank you for that. Well, that's a very positive note to end on. So I'd like to thank both of you, Dr. John Barrett, John, and Francisco Paco-Monfort. This is going to, and also to thank, of course, the European Kidney Patients Federation for setting up this webinar, which we hope is going to be the first of many. I think we're planning something in more detail and more depth around Rare Disease Day, which is 28th of February next year. So we will be working on planning that in conjunction with Juan Carlos and Daniel and team.
Thank you so much, Tess. We have recorded the session to increase the dissemination, and we will also make a short report with the most detailed aspect of this webinar, and which will previously send to you for all speakers and you for your review and suggestions. And thank you so much for your participation. And definitively in Leicester, they are in look for having a professional like you, Dr. Barrett, who strongly believes in what a patient needs, and they are must to be listened to. Thank you so much.
There are lots of us around. There are lots of us around. It's not just me. So it's about every country has them.
Oh yes, sure. Thank you so much. See you soon in another meeting. Thank you so much for your participation.
It's been a pleasure. Bye-bye.
Bye.
Thank you.
Bye-bye. Thank you very much.